Second white coat. Subscribe and like. Let's learn medicine together.
All right, today we're going to play detective. We're diving into a real-life medical mystery that starts with some really strange symptoms. And the clues are all hidden deep inside the human skull. So let's start putting the pieces together.
So here's the central puzzle, the big question of the day. And this isn't just some textbook problem, right? For a real person, this is a race against the clock. Doctors have to figure out what's connecting two problems that seem totally unrelated. Because that connection, that's everything. It's the key to the whole diagnosis.
Okay, so let's meet our patient. He's a 61-year-old man, and for about 3 weeks, he's been dealing with double vision that's just getting worse and worse. Now, here's the crucial detail. He has a history of metastatic cancer. That means cancer that has spread. So, as you can imagine, alarm bells are going off for the doctors. They're worried the problem isn't just in his eye, but somewhere way deeper, like the base of his skull. And that, of course, could be way more serious. So the investigation begins with a neuro exam, and right away, bam, they find the first major clue. And it's not about what they can see in his eye, it's about what his left eye can't do. The specific movement is called adduction. It's a fancy medical term for something super simple that we all do constantly without even thinking about it, moving your eye inward, toward your nose. And when a patient can't do that, well, that's a huge signpost for the doctors. It tells them exactly where the trail begins.
And here's why that's so important. The muscle that pulls the eye inward, it's controlled by just one nerve. So that nerve becomes our prime suspect. We're talking about cranial nerve number 3, the oculomotor nerve. Boom, we've got our first piece of the puzzle.
Now, here's a little map of the area. You can see that oculomotor nerve, that's CN3, winding its way from the back of the skull right into the eye socket to make things move. So a problem anywhere along that path could be our culprit. But, and this is a big but, it turns out this is only half the story. As the doctors keep digging, they find a second clue. And this one is even weirder. It has nothing to do with movement. It's about a basic protective reflex that has, well, it's just gone. Vanished. You know how if something, even a tiny eyelash, touches your eye, you blink without even thinking about it? That's the corneal reflex. It's your body's first line of defense for your eyes. Well, with our patient, when they gently touched his left cornea, nothing. No blink. That is a massive red flag.
Okay, so this reflex is a two-part system. It's like a doorbell. You have the sensory part that feels the touch, that's the button being pressed, and then you have the motor part that makes you blink, that's the bell ringing. Since our patient didn't blink at all, the doctors knew the bell itself wasn't broken. The problem was the button. The signal that something was touching his eye just wasn't getting through, and that points to a completely different nerve, a branch of the trigeminal nerve known as CNV1.
So wait a minute, we've got two different culprits now, one nerve from movement and a totally separate one for feeling. How on earth do they both fail at the exact same time? The only way is if there's a single crime scene, one spot where the damage happened. And that is the million-dollar question. It all comes down to anatomy. It forces the doctors to pull out their map of the skull and ask, where do these two totally different nerve highways cross paths? There has to be an intersection, a single spot where one problem, say a tumor, could cause a crash on both roads at once. Okay, let's just lay out the evidence one more time. We've got a problem with CN3, the movement nerve, and we've got a problem with CNV1, the feeling nerve. Whatever the answer is, it has to explain both. No exceptions.
And here it is. This is our location. The crime scene is called the superior orbital fissure. It's basically a little gap in the bone at the back of your eye socket. But think of it less like a gap and more like a super cramped tunnel that a bunch of critical nerves have to squeeze through to get where they're going. And, you guessed it, both of our suspect nerves, the oculomotor and the trigeminal, have to pass through this exact same tiny tunnel, right next to each other.
Okay, the pieces are really starting to fall into place now. This one single spot perfectly explains this weird combination of symptoms. But, good detectives always double-check. So let's make sure it's not anywhere else by ruling out the neighbors. This chart really spells it out. Look at the other nearby openings. The optic canal? Nope, that just has the optic nerve, which would mess with vision, and that's not our main problem. The inferior orbital fissure? Wrong nerves entirely. It's only that middle one, the superior orbital fissure, that has both our guys, CN3 and CNV1, traveling together. It's the only place that fits the bill. Case closed on the location. And now we can bring it all back to our patient. Remember his history of metastatic cancer?
Well, the most likely culprit is a tumor, right there at the base of his skull, putting pressure on that tiny little tunnel and pinching the nerves inside. And this collection of symptoms is so specific it even has a name: superior orbital fissure syndrome. The mystery is solved.
So what's the big takeaway from all this incredible medical detective work? Well, it all boils down to one really powerful idea in neurology.
This is what doctors call a clinical pearl. It's a little nugget of wisdom that's super useful. It's basically a rule of thumb. If a patient can't move their eye properly and they've lost that blink reflex on the same side, your brain should immediately jump to one and only one place: the superior orbital fissure.
So really, the big lesson is that neuroanatomy isn't just about memorizing a bunch of names. It's about knowing the map. It's a treasure map of the human body. And if you know it well enough, you can take a bunch of clues that seem random and follow the roads all the way back to a single hidden spot. It's how you find the X that marks the spot.
And that just leaves us with one final thought, doesn't it? This whole case was cracked just by understanding the body's internal wiring diagram. It really makes you wonder, how many other medical mysteries are out there, waiting to be solved, not with some fancy new machine, but just by taking a closer look at the incredible map we all carry inside of us?